Done. You have it?
Yeah.
And I'm going to try and share my presentation as well on the screen. So, wait, wait.
श्रद्धा इंट्रो तो वही है स्टार्ट करें
हाँ हाँ बिल्कुल शेयर कर स्टार्ट कर सकते हैं.
अंशु मैम आप इंट्रोडक्शन से स्टार्ट कर दो
Okay. Good evening, everyone, all present here. I am here to welcome Dr. Shraddha Lohia. She is MBBS MD, Fellowship in Pediatric Nephrology and Advanced Fellowship in Pediatric Nephrology from Singapore. And she is presently a consultant pediatric nephrology at Max Super Speciality Hospital, Vaishali, Ghaziabad. To us, she will be teaching nephrotic syndrome. So keep your doubts available. We will be there at the end of the session to clear all your doubts. And most welcome, ma'am.
Thank you so much for the lovely introduction. And so I'm going to have this more as a detailed, we can have a conversation per se. As we are going along the slides, you all can feel free to interrupt me at every point that you all feel essential. So, the definition of nephrotic syndrome has recently been updated to proteinuria and hypoalbuminemia. Proteinuria has to be of nephrotic range, which is one greater than 1 gram per meter square per day, and hypoalbuminemia of less than 2.5 grams per deciliter. With or without edema, and hypercholesterolemia is not present anymore in the definition. Okay. Then coming to
हेलो
G.
आपने ये पीपीटी से कैसे शेयर किया वही अभी पूरा स्क्रीन आ रही है 3-4 स्लाइड इकट्ठी है तो
कोई बात नहीं ना, चलेगा ना.
हाँ चलेगा तो सही है आपको कंफर्टेबल है तो चल जाएगा
मैं आपको शेयर कर दूं क्या प्रेजेंटेशन?
सॉरी मैम मेरे पास खुद के पास फोन है मेरे पास लैपटॉप नहीं है खराब हो रखा है
तो या तो फिर मेरे को 2 मिनट दे दो, मैं मेरा लैपटॉप ऑन कर लेती हूँ.
या आप 2 मिनट ले लो नो
ठीक है, स्टॉप शेयरिंग कर रही हूँ. मैं इधर से साइन आउट कर रही हूँ, लैपटॉप से साइन इन कर रही हूँ.
ओके
हाय, आपको आवाज आ रही है?
यस मैम।
हाँ जी।
So I'm sharing my screen. अब दिखाई दे रहा है?
यस मैम।
हेलो।
इट्स हाँ जी, इट्स विजिबल एंड आप कंटिन्यू कर लीजिए।
जी. So basically, nephrotic syndrome, the definition now has been changed completely to proteinuria and hypoalbuminemia. Edema may not be present, and hypercholesterolemia is not present. This is the most important factor. Then we have other things. We find.
हेलो।
Hi, sorry.
ओके, आई थॉट सम नेटवर्क इशू, दैट्स व्हाई आई एम आस्किंग।
Yeah. I am trying to share it.
आप एक मिनट स्क्रीन शेयर ऑफ करके दोबारा ऑन करो मैम।
स्क्रीन शेयर फिर से करूं? ओके. अब दिख रहा है?
स्क्रीन तो विजिबल ही है मैम। अब नेक्स्ट स्लाइड करो।
हाँ जी, हाँ जी,
ओके.
विजिबल।
अब ठीक है।
ओके, थैंक यू. तो coming to the management of nephrotic syndrome. So we all know the first episode of nephrotic syndrome is treated with 2 mg per kg daily for 6 weeks, and then we go on to 1.5 mg per kg for alternate day for another 6 weeks. This is the complete treatment of nephrotic syndrome for the first episode. In case of a relapse, or what we do is that we go treat the child until the child goes into remission with 2 mg per kg, maximum of 6 weeks if required. But once the child goes into remission, then you shift the child to 1.5 mg per kg for alternate days into 4 weeks. In case you have any issues such as infrequent relapses or frequent relapses, we treat the child accordingly. In infrequent relapses, we treat the only and only for the relapse, maximum of about 6 weeks. But in case the child develops frequent relapses or steroid dependence, if the child's dependence dose of prednisolone is less than 0.5 mg per kg or on alternate days for then we can continue steroids for 6 to 12 months. But in case it is greater than that, for some reason that's happened. Okay, so for the first episode, what is it that we do? The thing that we, the first thing that we would like to do for investigations is CBC, LFT, so that we have total protein and a lipid profile for the cholesterol, which is no longer required, which has completely changed. So no more lipid profile, and a urine routine to identify the protein in the urine. Additionally, we do certain tests which can be such as chest X-ray to identify if there's any history of tuberculosis. or if we're suspecting pneumonia. A renal ultrasound only if there's gross hematuria or we're suspecting venous thrombosis. In case of any additional features such as gross or persistent or microscopic hematuria, or secondary causes such as rash, joint pains, then we go for C3, C4, ANA, ASO. And in case there's jaundice or any liver abnormality that we feel exists, then we look for LFTs, Hep B, surface HbAs, hepatitis B, surface antigen, and HCV tests. Now, like we've already discussed, in case we are considering tuberculosis, we do a Mantox and a chest X-ray. In case we are worried about infection, we have to make sure we get the leukocyte, the blood culture, and the chest X-ray before starting steroids. And in case of atypical features, renal features, other than renal features, we look for serum electrolytes, like we've discussed, and that is when we are using diuretics. So what do we do in case the child hasn't recovered with 1 mg per, with sorry, in case of frequent relapsing nephrotic syndrome, if the child hasn't recovered and has a greater steroid dependence of greater than 0.7 mg or zero point 0.1 mg per kg alternate day, or has developed significant toxicity in the amount that the child has required steroid toxicity, is been on steroids, or has greater than one severe relapse requiring hospitalization, then we consider MMF cyclophosphamide first. If none of these are true and if it's less than 1 mg per kg, then we consider adding the child on levamisole for 6 to 18 months, and then consider next in line MMF. But despite being on levamisole or MMF, if the child is still having frequent relapses, then we move to cyclophosphamide. This arrow that exists between MMF, cyclophosphamide, and CNIs is where we consider a renal biopsy. And it is only reserved for difficult to treat diseases. And it helps us identify what exactly is the cause of nephrotic syndrome. So, what exactly happens when we are looking at this is the new KDIGO guideline. So it's KDIGO's approach to nephrotic syndrome, which is new onset. If the child is less than 12 years of age and has no family history, which is no family history, no syndromic features. So, like we've discussed, 4 to 6 weeks of daily corticosteroids, then move the child to alternate day of six weeks. In case there has been no response to 4 to 6 weeks, they talk about doing genetic testing, renal biopsy, consider CNIs on a low dose for podocytopathies. Otherwise, if it's just congenital nephrotic syndrome, then we consider RAS or RAS blockers, which help reduce proteinuria. And obviously, the child needs to see a specialist for these difficult issues. And in case that the child has is greater than 12 years of age and is syndromic, they or has a family history, then again we go ahead, do a biopsy, and or as per the requirement, do a genetic testing, and obviously has to see a nephrologist at this point of time. So, do we have any questions so far? Do you want to discuss anything at all? Okay. So the medications and how do you, monitor them? So prednisolone that is there, and if you've been giving it for alternate days, so what happens is long-term usage results in Cushingoid features, short stature, hypertension, raised intraocular pressure, glucose tolerance, cataract,
and elevated transaminases. Why is this important? Because we are worried about the the steroid toxicity that develops. And that is why we have all the other medication, with all of them are steroid sparing medications. A lot of the children and parents are pretty used to, and sometimes also change the medication themselves, which we have to insist they do not do it. Levamisole is the only side effect that exists is leukopenia with vasculitic rash, which is ANCA positive. The ideal dose that exists is 2 to 2.5 mg per kg on alternate days. Then, other than this, the next option that we considered was cyclophosphamide, and this is given only for 8 to 12 weeks at a dose of 2 to 2.5 kgs. This specifically is preferred in child who are above 5 years of age and under not not being an adolescent per se. So, in case the complications or the adverse side effects are leukopenia, alopecia, infection, discolored nails, hemorrhagic cystitis being the most common of it all. And there is a risk of gonadal toxicity, and which is why we try and avoid it in adolescent. And the only reason that we this is the only medicine that we use only once as a course. We do not repeat this course. So coming to the next drug, which is MMF, the dose is 600 to 1200 mg per meter square per day. And this we repeat CBC, KFT, LFT every 3 months when the child is on it to monitor. And the adverse side effects are basically abdominal pain, diarrhea, nausea, weight loss, viral warts, and leukopenia. Elevated transaminases generally are picked up first. So this slide is the most important slide, which is to show that there is impaired glucose tolerance, there is hypertension, cardiovascular diseases, hyperlipidemia, metabolic syndrome, Cushingoid features, obesity. Behavioral changes are also seen, such as severe psychiatric reactions. I have had one patient run away from home. The reaction can be so, drastic at times. Infections are a known issue in nephrotic syndromes, and growth retardation, because steroids have this anabolic effect on bone health, and they also lead to osteoporosis. Adrenal insufficiency can happen if sudden withdrawal of a sorry, if adrenal if sorry, if there is sudden withdrawal of prednisolone, and long-term use of prednisolone can result in cataract and raised IOPs. And this is why we recommend annual checkup for children who are on long-term steroids. This is the most important part of this slide, which I urge everyone to use prednisolone very, very with a lot of caution. So, coming to a vaccination, this is a discussion. Please tell me, what would you do if you have a 4-year-old child with completed immunization as per IAP schedule, and this child has completed their nephrotic syndrome treatment for the first episode? What is it that you would recommend to the child? We have 39 participants. I'm sure one of you all would be able to help me with vaccination. Okay. So what I would want to do is I would want to give the child pneumococcal vaccine based on the number of dosage this child has received. And since this child has only IAP's schedule completed as immunization, so we'll give them first dose of pneumococcal 13, 14, 10, whatever as per your liking, and then a 23 valent after 8 weeks. The second thing that we recommend is influenza vaccine, which is given annually. These are specifically for, why do we recommend these? Because these viruses are actually encapsulated, and this is why these children are a little more predisposed to it. Another case that we have is a 3-year-old child with who has completed immunization, and this is national immunization schedule. This child has completed the first episode of nephrotic syndrome 1 month ago. Now the sibling has skin lesions. The child's sibling has skin lesions which are similar to chickenpox. What is it that I would want to do? This is a very common scenario that comes up, and it's summer right now. So, any advice for me? So, can we give this child varicella actually now? So, this child has completed its treatment 1 month ago. So we can actually give vaccines now, and especially for live vaccines, we want to give it 4 weeks after having stopped steroids. So I have a role for the parents that I would really, really want to include. I want them to ensure that we, as work as a team with the parents, ensure that the child has a normal childhood. The parents really need to maintain a urinary diary so that we have an appropriate idea as to what dosage of the drugs are going, if any other drug other than prednisolone is given or something like a steroid sparing agent is given. Remarks such as cough, cold, any other issues, any change in drug doses, weight if taken suddenly. This appears very futile sometimes to a lot of parents, but insisting and getting this done goes a long way in managing nephrotic syndrome really, really well. Other than this, we want to ensure that the child has a good diet. Diets have been completely changed as per the US guidelines now, and we recommend 2 grams of protein per kg per day for children. And obviously, we want to avoid as much of sugar and fat as much as possible while the child is in acute state or is leaking protein. And then they can come back to their daily diet. As for schooling, we do want the child to attend school, not miss school, enjoy all the activities, as long as they maintain personal hygiene, wear a mask, everything in terms of avoiding infection, it is a pretty good way to ensure that they do not have relapses, and appropriate and timely, vaccination and OPD follow-ups is absolutely, absolutely essential. Other than this, we want to make sure that we do a growth charting for the child, because if the child is growing short and is moving or faltering at growth, we will know if it's because of the steroids or it was because of an acute event such as illness, hospitalization, or just fussy eating of the child at some point of time. So, thank you, and I'm happy to take any questions you all have.
Thank you so much, Dr. Shraddha ma'am. I any questions if any person has from Madam? Uh, so there is one question. Can you explain no response to steroids next step?
Yes, so this child will be a steroid resistant nephrotic syndrome. I'm assuming in the first. Can you see the question? Is it the first episode, right? I'm assuming it's for the first episode of nephrotic syndrome. And if the child hasn't responded for the with a 2 mg per kg in 6 weeks, regardless of it being a first episode or another episode, if the child hasn't gone into remission, we want to do a renal biopsy for the child and identify what exactly is happening, because steroid resistance can occur at any point, any episode, and has a completely different management for which we take care, like has a completely different guideline for management.
Absolutely, ma'am. So whenever a child comes to us and has received 6 doses with 6 weeks of proper 2 mg per kg of steroids with proper compliance, proper dosing, as per body surface area, preferably, but not then by body weight, and has no infection, has whether an overt or subtle, then we label the child as steroid resistant and we offer the child with renal biopsy. And as Madam said, that this steroid resistant nephrotic syndrome can have FSGS kind of picture or any other nephrotic pictures for which we need biopsy as well as some biochemical tests. The next question, ma'am, is that, ma'am, if children are drug incompliant or non-compliant repeatedly 3 to 4 times, shall we start as first episode?
So the non-compliance is, it depends on how long the non-compliance is. If it's a dose or two, it is okay to continue. But if it is, um, big, first of all, we want to know if the child has completed a 6 plus 6 week course. So if the 6 plus 6 week course is over, you have no need to treat the child repeat as 6 plus 6. If there is only non-compliance for a dose or two, it's okay. But if it's longer, then we have to have a look at the child, how they are doing. And based on that, we can consider restarting the entire 6 plus 6 weeks if needed.
Yes, definitely, ma'am. If this depends on how the child has taken, right? So the next question is, in a child with fever and if he's having relapse, do we need to start steroids immediately or wait till fever is reduced?
So, Dr. Deepti, it's very, so this is something that you have to look at what the child is having medication wise. If the child is already on steroids, like say I have a 15 kg child and the child is on 7.5 mg of steroid consistently for the last 4 weeks and has had a relapse, then I am not going to increase this dose to 2 mg per kg if the fever is there. But if the child has been off steroids for a while and then developed fever, then first I'm going to treat the infection. After the child has, fever is in control, or at least has received at least 3 days of antibiotic and is now having urine protein plus in plus 2 or plus more than that, then I would consider adding a stress dose. Um,
Perfect.
Somebody else was asking an albumin infusion indication. So
Yes.
basically, albumin is not treated. Indications of albumin infusion is not less than 2.5 mg per kg as ideally taken. It is based on certain things such as symptoms such as the child having difficulty in breathing, anasarca, genital edema, resistant edema. So these are the only actual indications of giving a child an albumin infusion.
Perfect,
And
ma'am.
whenever we give the albumin infusion, you do want to give a diuretic very, very slowly as well. Give it as an infusion so that the blood pressure doesn't drop. Uh, I am not sure of the role of albumin when serum albumin is less than 1.5 grams. I don't understand this question. Can you give me a follow-up question for this? Whoever has given this question, I'm assuming it's the albumin infusion only that you mean. Then we have an anonymous question again. Can we give vaccine while on alternate day steroids? So basically, on alternate day steroids, you want to come down to the minimal possible dose of steroid that you can give the child, and consider starting live vaccines. Killed vaccines. Any killed vaccine is fine to give, but you have to remember that the response is not going to be as good as you give when the child is off steroids. No live vaccine is to be given on alternate day steroids, at least unless there is no live vaccine that we give on alternate day steroids. Um, then we have another question. Again, fever with relapse. Yes, I think we've already answered this. I am not sure about this question. Immediately, we have to do renal biopsy, findings of biopsy. Uh, do you understand this, Anshu? This question I am assuming that it must have been at around 6 weeks.
Yeah, yeah. That is the I think that is the question that we want to ask as to like, do we need a biopsy immediately after 6 weeks of steroids, or can we wait? And
So honestly, if the child hasn't gone into remission by 4 weeks, I start counseling the parents. This is my personal opinion because mental prep alone takes a lot of time for the child's biopsy. And yes, it's best to do the biopsy by the 6th week so that we have an answer and we can treat the child accordingly. Any child which has not gone into remission by 4 weeks is going to be a difficult nephrotic syndrome. If you've seen the Bell's curve, you see that 93% of children respond by 4 weeks. And the ones who don't, the 4% that respond by the end of the 6th week, this 4% will be very, very difficult to treat.
understood. Yeah. And also they are asking what are the expected biopsy finding if we are doing it for steroid resistant nephrotic syndrome.
it can be all five categories. We do need a family history and sometimes even genetic studies. I mean, finding of biopsies are the same: minimal change disease, FSGS, mesangial and mesangial percentage varies based on, what we are, what is the age of the child, when the child is, like family history. These are the basic things that we get. And if we do a biopsy little too early on, then sometimes FSGS is goes undiagnosed and it comes up as minimal change nephrotic syndrome.
Definitely. So the biopsy finding could be FSGS in a steroid resistant nephrotic syndrome, and the percentage is high when as compared to steroid sensitive. The second category, as Madam mentioned, minimal change. Then we have membranous, if more common in the adolescent age group. Then we have diffuse mesangial sclerosis. This can be in a patient with query congenital nephrotic or infantile nephrotic. Then we have membranoproliferative GN, which is nephritic nephrotic onset of disease. Next question is, Madam, what amount of IV fluid, oral fluid, should I advise to the patient after admission?
I am not sure how to answer this question at all. So I am assuming you mean when the child is in remission or in relapse. I am assuming this has to be done for a child in relapse and has anasarca.
Hmm.
So basically, instead of IV fluids, I would prefer giving 400 ml per meter square plus albumin and diuretics rather than IV fluid. The child, you restrict the oral fluid as well because you'll be giving, you'll just be adding to the edema. And overall, you do have to see why the child is admitted. If the child is dehydrated, having loose stools, then you give a lot of more fluids as per requirement. I um I don't know, Anshu, what else to add to this. Do you have to add anything else?
Uh, Perfect, ma'am. Actually, that is there. So, what the crux what ma'am wants to say is to you is that IV fluid has 154 MEQ if we are talking about 0.9% normal saline, and this much salt is not recommended for a patient of nephrotic. As you know that the edema, the main pathogenesis is because of salt and water retention. So we restrict the salt to these children so that there is minimal edema, and we are struggling with less edema and we are able to take care of that. So we restrict the child to minimal oligouric level of fluid, that is 400 ml per meter square, plus urine output to as much as possible. But there is a catch in this. Whenever the child comes to you with nephrotic syndrome with any kind of sepsis, shock, dehydration, then our first motive is to treat the sepsis and the shock and not about the edema. Edema is the second is second to us. The first is to save the life of the child, to make him or her hemodynamically stable, and then we cater the edema part or the anasarca part. Understood? So if we require IV fluid because of any reason, then we give. If if at all the child is stable, hemodynamically all right, no hypotension, no tachycardia, then the next step is to take care of edema, and the first step is salt and fluid restriction.
Thank you,
The
Anshu, for
next
putting it well. The next question is, what is your experience
congenital
with congenital nephrotic syndrome and its
nephritis.
management? So, congenital nephrotic syndrome, the first thing that you want to do is do a renal biopsy. After renal biopsy, genetic analysis. These are two of the two most important things that will guide your management. Other than this, you're also going to send in torch IgG and IgM. I have had, um, based on this, if there is any infection that is there, you treat the infection, and congenital nephrotic syndromes sometimes does fix itself just with the infection management if it is acute. And if it is been chronic, has affected the kidney, then it will just continue, but the dosage requirement of other medication drops. Um, so that is one part of investigation. Second part is, um, depending on treatment. So the treatment base is based on a lot of medica what comes positive. So in congenital nephrotic syndrome, if you have Torch positive, you treat accordingly. If it is because of a particularly genetic issue, then ACE ARBs are the answer. If it is because of a podocytopathy, then low dose CNI helps. So I have seen for for congenital nephrotic syndromes with CMV, and having treated the CMV drastically improved the child's outcome, and two of them completely recovered. One was lost to follow up because they moved, and one child required a long-term um, NVAS treatment. So yeah, that was my mm, congenital nephrotic syndrome. And we have one more question. Do bee stings cause nephrotic syndrome? Um, Anshu, do you want to answer this? Bee sting causing nephrotic syndrome?
So, ma'am, there are only case reports based on bee sting. Bee sting, whenever you suspect any edema post bee sting, always suspect anaphylaxis first and then anything else. Okay. So once you've ruled out all anaphylaxis or anything else, there are case reports wherein these stings, because of some immunological reaction, they provoked a nephrotic syndrome in a genetically susceptible child, right? And
Oh,
the management is same. So it is just like a cough and cold provoking a nephrotic syndrome. Similarly, a bee sting provoking a nephrotic syndrome. The management is same as that of primary. Okay.
oh, and the percentage of relapse after a first episode of nephrotic syndrome. So I would say 30% of patients after a first episode do not have a second episode. So that leaves us with 70% of patients with nephrotic syndrome who have a relapse. These include infrequent, frequent, steroid dependent nephrotic syndromes as well.
Perfect.
Anything
So
to add to any of this? No more questions, right? Other than this?
yeah, no more questions. With these many questions, I am hoping that all of you attended it well, and ma'am was perfect in answering all your questions. Any more questions, do let us know. We'll be happy to answer. Thank you so much, ma'am,
Okay,
for
thank you so much, Anshu. Thank you so much for managing this. And thank you
we
for the audience for being so patient and asking us all your questions. You want to complete?
yeah yeah, thank you, ma'am. So to conclude that nephrotic syndrome is a disease in itself, and for the best management of the child, it is always better to counsel the parent at the first episode as to what the prognosis will be, how the child is going to progress, and uh, what all things are to be taken care of, as madam told you regarding protein diary, regarding the relapses. So that all has to be explained to the child to the parent or the guardian for the best response that they would want. And always screen for secondary causes at the first episode itself if you are at a good center and the parents are affording enough. Yeah. Should we conclude, ma'am?
Thank you.
Yeah. Thank you, ma'am.
Let's
Thank you
sign
so
off.
much.
Thank you, ma'am. Good night.
Good night.